My name is Daryl Moon, and it's my pleasure to be with you today. The very best healthcare system model in the world is the aspirational healthcare model. It's both superior in outcomes, and it only costs half the cost. South Central Foundation's NUCA system of care in Alaska is the best example of this model of aspirational healthcare. They're the only healthcare system that has won the President's Malcolm Baldrige Award twice, once in 2011 and again in 2017. Countries come from all over the world to Alaska to learn how the NUCA system of care could be so much better than all the other systems, half the cost and far better outcomes. Well, wouldn't it be nice if we could all purchase healthcare from South Central Foundation's NUCA system of care? Well, we can't. However, the closest thing to the NUCA system of care is Redirect Health's program that is available to individuals and employers across the country. I'm honored to have as my guest panelist today the Medical Director of Redirect, Dr. Janice Johnston. Welcome, Dr. Johnston, and thank you for being with me today.
Good morning. Thank you for having me.
So first of all, Dr. Johnston, will you take just a minute and introduce yourself?
Sure. So my name's Dr. Janice Johnston. I'm the co-founder and chief medical officer for Redirect Health. And I'm a family practice physician by training. I'm trained in Toronto in Canada. Moved to the States in 1995 and learned a lot about this complex American system here. There's a lot of pieces, a lot of middlemen, a lot of confusion, differencing in pricing and access and all sorts of things. And so after learning a lot about the American system, how it worked, my husband and I, who was the other co-founder of Redirect Health, we decided to change things up a little bit for our company. We had clinics here in Arizona, and we decided to go self-funded as a company. And probably a little bit of a risky endeavor for a small business such as ours. But because we were in healthcare, we kind of thought we would take it on. And boy, did we ever learn a lot. And the things that we've learned have made us not only successful in our personal business, but we've created a new model of healthcare and offered it to other businesses around the country and making the same impact for employers around the country.
Awesome. I've mentioned many times on these webinars that the primary care system in the U.S. is badly broken, and I'm a big fan of the new model called direct primary care, where primary care team is aligned with the customer and works towards keeping people healthy in the first place. This is clearly the foundation of an aspirational healthcare model. Redirect Health has gone one step further and created a virtual direct primary care program and then built this entire health plan around it, which is why I believe it is the best option employers can purchase right now that's available on the market. Not to mention the fact that it's much less expensive than a traditional health insurance option. I think it's so fascinating how you built a virtual model of direct primary care. Can you describe that for our listeners?
Sure. So, often with a direct primary care model, a patient is paying a certain membership fee per month to have access to one person typically. And in our model, we have 24/7, 365 days of the year access to virtual primary care. And we have a team. Certainly our membership base can coordinate just with one person on a regular basis. And so it's great to have immediate access to primary care without any kind of barriers, without any kind of cost to that. And that we're easily available either through a phone call or through using our app. We have our members' medical records, of course, readily available to us. And so, opposed to what you would typically find with your typical telemedicine type services that are out there, is that we've got a lot of background on you. We have the ability to make referrals, order blood work, of course, order, pharmaceutical treatments if needed, that kind of thing. But we also coordinate with physicians in their local community. So even though we might not have a brick and mortar facility in their local community, we work with the doctors that they're normally used to seeing, but we're able to facilitate and direct care. It's kind of like having the PCPs have their own on-call doctor system, basically, right? And so we can manage a lot of the background work that happens in terms of getting people the right care at the right price at the right time for them, helping with referrals, helping with pricing for, higher drugs, higher priced drugs, higher priced radiology services, all of that kind of thing.
Well, actually, I think that is so cool about how you've built this virtual model working in tandem with people that can put hands on the patient, and that you often use the doctors that the patient already knows. I think is such a cool model. So tell us a little bit about, because a lot of primary care can be done virtually. There's a lot of things that you don't need to put your hands on the patient. But when it is necessary, what is it, maybe 20, 30% of the time where you need someone to go in and either get a lab test or an x-ray or have the patient see the doctor. How do you talk a little bit about how you coordinate that and what that experience is like for the patient?
Yeah, so, in any type of medicine, so much of what's going on with the patient is actually based on history, right? The question taking and getting the background information, perhaps getting some blood work or radiology types of tests. And so having the ability to really assess our members and follow up with them on a regular basis, we can really make some good recommendations for care. A lot of people think of telemedicine as primary for, I woke up and I've got pink eye and I think I have pink eye. That's pretty straightforward, right? I mean, typically we're going to prescribe some drops for that kind of situation. But say, for example, someone calls in with symptoms of depression or anxiety. That's not a hands-on kind of thing, right? That's typically a talking kind of thing. And so if we want to recommend some counseling or we want to recommend treatments like an antidepressant, that kind of thing, certainly that's easily followed through telemedicine. The other is just following up on test results, right? So when you go get your physical every year and something's off with your blood work, what does your doctor typically do in our traditional world is that they ask you to come back, right? And that's because that's the mechanism of payment for the physician. In this model, we can easily do that through a virtual visit. It's all included as part of their direct primary care membership. So, we can guide them to the next steps that they need to do just based on that. The other part that I think is super important is the concept of watchful waiting. So if I talk to you today and you said, hey, my back hurts, instead of having you come in for a direct examination, oftentimes what we would do, especially what I would do, say, for my brother or my sister, my friends, is I would, give them some exercises, stretches, things like that to do, maybe counsel them on some anti-inflammatories, ice, those kinds of things. And I would have the ability to check in on them very quickly afterwards, so the next day or 2 days afterwards or that kind of thing. Tell me how that worked for you, right? So watchful waiting means I'm going to do some conservative measures before I really kind of jump to the big things. That same thing kind of happens even with children with, say, like a low-grade fever. And oftentimes, the parents are doing all the right things, right, already. They're giving them fluids, they're giving them Tylenol and kind of watching them. And sometimes by the morning time, a lot of these symptoms have improved. We do see, oftentimes we jump to giving antibiotics maybe a bit too quick, right, in our type of medical society here. But in other parts of the world, they don't do that, right? And so watchful waiting is a very, very useful concept for us that we can, give some advice, follow up on a quick basis and see what happens. But, oftentimes we need to progress very quickly to a higher level acuity kind of setting, right? So it might be an urgent care or an emergency room where we need to move fast with that kind of stuff. So, or, I might do a virtual visit with you and you say my belly button's sticking out. I can see it. I know that it's an umbilical hernia. I don't need a direct exam from that. And typically with some good history taking, you can get a good idea, is this an emergency type of situation? Or is this something where I can send you to a surgeon and get it evaluated and possibly fixed, right? So those are the kind of concepts that we use quite a bit. We're able to communicate with our membership base very, very often. And I think that really, really helps us to do a good job in terms of following up, but also keeping the cost down as well.
I love the example you used of if a doctor was your dad or your grandpa or your brother and how you would work with that doctor. I love that example because that's really what you've built, is the fact that when people think of telemedicine, they think of, well, it's in the middle of the night. I'm going to call a doctor. I have no clue who the doctor is. The doctor doesn't know anything about me, but I need to talk to a doctor right now. That's a very different thing than what you've built. What you've built is, I'm going to call my friend, someone that I know that it's, that has my records, that has my whole history, that I can ask questions of, and they can relate to me as my primary care doctor. And I don't need to go in. I don't need to get up. It's more convenient. It's about healthcare being built around the person and really creating a friend or family member, doctor, for everybody in the plan. I love that example.
Yeah, that's right. The other thing to keep in mind is that a lot of people don't have the time to take off of work, right? And if they do take off of work, it's going to cost them money to do so.
Right.
So the ability to have your visit at a time that's convenient to you, whether that be in the evenings or on the weekends or early morning before you go to work on your lunch hour, that type of thing. In our traditional healthcare model that we have in the U.S., that doesn't typically work, right? So doctors' offices typically will work, the 9 to 5 kind of shift. A lot of them take off Fridays, they're closed for extended periods over the lunch hour, and that might be when people have the time to go get their care, is during their lunch break and things like that. So we'll time our visits for people's break from work, and we are very good about making sure that we call it a schedule a call back, and so we make sure that we reach out during that time, so because we know that that's the most convenient for the patient.
Right. I truly believe that you've created the standard on how to be proactive in addressing health issues for your members. Can you describe how you and your team go about not just simply reacting to a health risk, but actually identifying health risks and then proactively addressing those? That's one of the best things about what you do.
Yes, so we have a couple of different models that we use to approach that. We obviously can identify people who are at higher risk, right? If I've just sent you to the emergency room, or perhaps you've just been released from the hospital, that kind of thing, I want to make sure that we're touching you on a really, really regular basis, daily, sometimes more than once a day, sometimes every few days, just to make sure that you have everything that you need, your questions are answered, things that are progressing in terms of your treatment plan. And if things need to be tweaked in terms of the treatment plan, then we can make those adjustments as we go. So those are our high-touch members, and you could fall on and off of those depending on what's going on with you. People who are having surgery would be on our high-touch members, and just to make sure that they understand what the costs are going to be, where do I go to show up, do I have my follow-up with my surgeon, all of those kinds of things. We want to make sure that we're acting both in a medical capacity and a case manager type of situation too. So that's one type of person, and then typically those people will fall off in terms of we want to touch them every week, just to kind of give one more chance to say, is everything good? Are we progressing on the right path? And then there are other folks who have chronic type of situations, right? So it could be diabetes or depression or, multiple comorbidities that we identify these members as being they could be potentially frequent flyers, and so we want to make sure that we're reaching out to them on a regular basis so that they don't fall off in their care. We all get busy, and so it's easy to kind of fall off in terms of your care with your regular follow-up. So that way we can keep on top of them in a not in an obtrusive type of way, but on a periodic basis that we can reach out to them and just make sure that they're on track with their care.
Like a good doctor would.
Yes.
That's what you would expect from a family doctor, is that they're going to be following up with you. And I love the fact that if somebody needs a test in order to monitor how they're doing, you proactively make sure that those tests are being done. If they need their inhaler replaced, you're proactively working to replace those inhalers. I think it's amazing how you don't just wait for someone to have a symptom and then show up at the doctor. You take a proactive approach, which is the way healthcare should work.
Yep. Yeah, absolutely. Yeah. So, it's different for folks when they first sign up with us, but it doesn't take long before they feel like they are engaged with our team and really can see the benefits of what we're doing for them and taking the brunt work out of trying to navigate this really crazy complex healthcare system.
And it is. So in addition to being proactive amongst those members of your plan who have health risks, you also have a whole team that is communicating with your general population to encourage them to live healthy and to remind them that that you are there for them when they need you. Can you describe their role and some of the examples of things you do to proactively just stay in front of your membership to remind them that you're there and available for them?
Yeah, so when a new member comes on with us, we have a program where we proactively reach out to them just so they know how to use us and when to use us and what we're there for, and that we are available 24 hours a day for them. We do want to make sure that when we bring somebody new on, that we know what their issues may be or what their concerns may be if they have something coming up. Even if it's a few months down the road, it's better to be proactive than it is to be reactive with things. So that's the approach that we have. We do use some population health tools as well to make sure that we are identifying maybe gaps in care that could be present for our membership. So, in terms of, have you had your mammogram, all those kinds of things. So we make sure that they are getting the prescribed routine preventative care as well.
Nice. So a study that was done by Johns Hopkins University School of Medicine found that medical errors are the third leading cause of death in the United States. Wow. When I saw that, I was like blown away. When I asked my daughter, who is an ICU nurse, about that, her comment was, well, I think people should work harder not to get sick in the first place. That's a pretty insightful comment. Almost 90% of all healthcare costs can be traced back to lifestyles and behaviors. So clearly, individuals are accountable for the root cause of many of those medical errors, and your program is working hard to help people stay healthy in the first place. However, many of those medical errors come from the lack of coordination that so often exists in the healthcare system. Many times the system relies on the patient to be the primary coordinator between the different silos within the system. The primary care physician, in my opinion, should be playing the quarterback and play a key role in coordinating the patient's care between the various specialists. Can you talk a little bit about how Redirect Health facilitates this coordination to optimize care and to minimize those medical errors?
Yeah, so when we interact with one of our members, we're doing an intake consultation and notes, just like you would do if you were in your doctor's office. It's the same kind of setting. We're able to transmit that directly to the in-person physician if that's needed. Also, kind of tee them up, right? Serve them up, these patients, so they're may not be 100% worked up in terms of what their issue is, but there's a good start to that. And so by teeing up and having medical records available to our physicians on the ground, that helps tremendously. Certainly having physician-to-physician interactions on a regular basis on behalf of our really high-touch members, that's very, very helpful too. And just having a compounded medical record that is very comprehensive and has all the details in place, I think is very helpful to make sure that things don't get slipped through the cracks moving forward.
Well, and the fact that doctors often don't get paid to talk to other doctors in a fee-for-service environment where the doctors are primarily doing the things that they're going to get paid for, that's where you have this gap where doctors aren't talking to other specialists or not talking to the primary care physician. And the primary care physician's really just sending people to a specialist. The fact that you've got a family doctor model where that doctor is playing the quarterback, that communication between the various physicians and the coordination of care isn't on the shoulders of the patient. And I truly believe that's where a lot of the medical record or medical errors occur, is because we're putting communication in the hands of the patient rather than the doctors working together. So I love the model you've built where there is a family doctor, and that family doctor is coordinating the care between the specialists to not only minimize the errors, but to maximize the care and the recovery for the patient.
Yep, absolutely. You nailed it.
So we've talked about coordinating care and the hospital services. Let's talk just a little bit about the controlling costs, because you mentioned a little bit earlier that that's a big piece of what you do as well. I was speaking to one of your members just the other day about a family member of theirs who's looking at having a fairly significant surgery on their spine. He mentioned that your team did some proactive work in identifying where that surgery should be done. At one hospital, the charge was going to be close to $150,000. But at a different hospital with one of the very best surgeons in the state, the cost would only be $50,000. That's $100,000 difference. That's a lot of money. And so often in healthcare, the most expensive care is not the best care. The best providers are often able to minimize complications and provide those services at a fairly lower cost because they don't have so many errors and complications. Can you share your thoughts on this?
Well, I don't know that it's necessarily based on having complications and things like that in certain settings. I think pricing just varies across the board, across the country. One hospital to the next can vary tremendously. And, we've even found that a good example that I've had in the past is where I have one OBGYN who works out of two hospitals. And, to deliver a vaginal birth, no complications, that kind of thing, we usually look around the $5,000 to $6,000 range all in for that. Whereas if you go to one hospital, we'll see it in that range. That's pretty reasonable rate for that. But if you go directly across the street or a mile or two down the road, you could be looking at $20,000 more. And why is that? There's really no difference in the care. There's no difference in the complication rate between hospitals or the care between hospitals. And even in this situation, the doctor was the same doctor. So you would expect that the care would be pretty much identical. So we do obviously find that self-pay rates that we find for people vary greatly. Some places will offer things that are more in line with what an insurance company would pay, where others, they really take advantage of someone that's without traditional insurance. So we're very good at knowing what those customary and reasonable rates should be, bundled pricing, all of that kind of stuff. So in terms of working with those facilities, and we always want our patients to get the best of care, right? Even though it might be cheaper at one facility or the other, we're not looking to get some kind of bargain basement type of care. We want the best of care, but we want not to be taken advantage of in terms of pricing. And I think that's what our country needs as a whole, is to get some standardized types of arrangements for pricing, and that would honestly help a lot with the issues that we see in our healthcare system today.
Well, and just to complement what you're saying, we have the most expensive healthcare system in the world, twice as expensive as most other healthcare systems. And a lot of it is waste and just unnecessary additional costs. And a lot of it is what we were just talking about. Yes, if you have an emergency, go to the closest hospital. Don't worry about calling anybody. Just get there as quickly as you can. But that doesn't represent a lot of our healthcare costs. Most of our healthcare costs are planned, predetermined, it's expected types of surgeries and events that can be either negotiated or can be coordinated ahead of time. And I think that's what your organization has done extremely well, because you've got a family doctor model who's not just putting Band-Aids on people who scrape their knees. They're actually coordinating the care and taking ownership on behalf of the member for their healthcare services. Oh. Is there anything, maybe in closing, since we're running out of time, anything that we haven't shared or talked about that you think is an important message that our listeners should know about the way you do healthcare?
Yeah, I think just overall that what we find is sometimes the healthcare programs that employers will offer to their employees, following the more traditional commercial type of payers that are out there, while they may offer great coverage and access to care, sometimes the premiums are just not within the reach of their employees, so the premium per month. And then even if they do pay that premium, when an event hits, being able to afford a deductible can just make the care unattainable for people. So offering our program, which helps to address some of those things, really, I believe, gives great access to the broader spectrum of employees across the country, especially those that might be earning sort of, more minimum wage or a little bit higher than that. So that's probably the primary thing, is that there's a huge swath of our population here in the U.S. that is not insured, and it's just because they can't afford insurance, and so they choose to opt out of that system and kind of roll the dice, I guess, knowing that if something happens, they'll just deal with it at the time. But in the meantime, they can't really just afford to pay something that honestly they can't afford to use when the time arises.
Well, and I've heard this statistic, I don't have the reference, that medical costs are the biggest factor in personal bankruptcies, and that the majority of the people had insurance. Even though they had insurance, they still went bankrupt, because you can have a out-of-pocket maximum that's $20,000.
Yeah.
And I'm sorry, there's a lot of people that can't come up with $20,000 for some major event, that even though it may have cost $2 million for the entire cost of the program, that person's responsibility could be $10,000, $20,000, $30,000.
Right.
Where within your program, your maxes are so much less than that, and you make it reasonable for me and others to say, I'm not at risk. I have something there that if something catastrophic were to happen, I'm going to be okay, and I'm not going to be financially put out of business because of this. And I have a family doctor helping me coordinate that.
Yep.
So again, Dr. Johnston, thank you so much for being with me today.
All right, thank you. Thank you, Daryl. It's nice to see you.
Take care. Have a wonderful day.
You too. Bye-bye.